So hello. Today I've decided to take a class that is slightly different from a regular theory classes. This is my perspective of a case presentation from the student's angle for thyroid gland examination. So how a undergraduate student of an MBBS or a BDS course should present the case history and the general examination and the local examination and the summary of a patient who presents with a thyroid gland swelling and how it should be documented and how it should be presented. So this is my take on that aspect. This is a first session where we'll be discussing about the history and how it should be written and why we have asked those questions. So the topic would be slightly narrow-minded in the sense that we are looking from the student's angle, how it should be documented, and with respect to the thyroid gland in this case. So, case presentation format, thyroid gland, and this is the part 1, history. So this shows the posterior aspect where you can see the esophagus, the back of the thyroid glands on either side. You can see the vital structures, the common carotid vessels, the vagus nerve, the rectolaryngeal nerve, the superior laryngeal nerve. You can see the epiglottis which goes on to the trachea. You can see the anterior structure slightly. So same in a simplified way. So these are all the things that we need to consider while taking the history. So it begins with the biodata. So you have the name, age, sex, profession, and residence. So the name is not of much relevance. So the age. By asking the age of the person, you have a certain thyroid conditions that are seen in certain age groups. So in children, as young as 1 year old itself, you can see a medullary carcinoma thyroid. In younger children also a medullary carcinoma thyroid can be seen, that is 8 to 12 years. Then hypoplastic goiter, colloid goiter are usually seen in the teenage, that is 14 years, 16 years, as that is the first stage of goiter. Similarly, thyroiditis, Hashimoto's thyroiditis, other forms of thyroiditis may be seen during childhood. Now, a young adult, that is the age 20 to 30 years, again, thyroiditis can be seen. Papillary carcinoma thyroid can be seen. In the middle age, that is, let's say 30 to 50 years old, you can get thyroid carcinoma that can be papillary, medullary, or follicular type. A multinodular goiter is frequently seen. Thyroiditis again is seen. In the elderly age group, that is above 50 or above 60 years old, again thyroid carcinoma is seen, medullary carcinoma, follicular carcinoma, and anaplastic carcinoma. So the more common variant of papillary and follicular, papillary is slightly seen in slightly younger age compared to follicular. And anaplastic is definitely seen above 65 years of age. Multinodular goiter again is seen in the elderly age group. So based on the age, you can see these conditions affecting the thyroid gland. More commonly, these are, that's why I have categorized them as per the age. Now, regarding the sex of the patient, thyroid disease, all forms of thyroid disease generally is known to be more common in females. Thyroid malignancy is also more common in females. But if a male patient presents with thyroid swelling, the chance of it being malignant is much more compared to a female patient. Even though the incidence of malignancy is more in females, when a male patient comes with a thyroid swelling, the chance of it being malignant is more. Profession, there's no direct relevance. Regarding the residence, certain areas are known for endemic goiter, hilly areas, iodine deficient areas. In India, it mainly includes the Himalayas, the northeast India, and a few places in Tamil Nadu, Karnataka, Maharashtra are known to be iodine deficient. So goiter is more frequently seen in such areas. Now, regarding the presenting complaint or the chief complaint, that is the complaint that the patient presents to the doctor with. So, one of the most common complaint is swelling in the front of the neck. So, and that would be a duration of maybe 5 years or 1 year or 10 years accordingly. So, here I would like to stress the point that swelling in the front of the neck is equivalent to a swelling in the anterior aspect of the neck. I would prefer that the student avoids saying swelling in front of the neck. Now, in front of the neck and in the front of the neck are slightly different. In the front of the neck refers to the anterior aspect of the neck, while in front of the neck refers to all the things that are in front of your neck. It could even mean the person standing in front of you. So, I would prefer the words swelling in the front of the neck, and the duration can be mentioned. Now, other presenting complaints include difficulty in swallowing or difficulty in breathing. So, some patients may present directly with difficulty in swallowing or breathing, but they also tend to have a thyroid swelling more commonly. So, it is better that I would recommend that in order to uncomplicate things, it is better to add that as a pressure symptom or a negative history rather than adding it as a chief complaint, especially if there is already a neck swelling. Similarly, hoarseness of voice. This also is preferred as a pressure symptom or a negative history and not as a chief complaint. So, though the patient may tell you that there is hoarseness since last 2 months, but still there may be a swelling there which is there for 5 to 10 years. Now, the next complaint frequently that is told by a patient is recent weight loss in spite of increased appetite, or recent weight gain in spite of decreased appetite. Now, the first one actually refers to thyrotoxicosis, and the second one refers to hypothyroidism. So, patients may say that they are very hungry and they are eating a lot, yet they are losing weight. So, this again, rather than saying it's a presenting complaint, if there is a swelling, it's better to say it as a part of the negative history. So we'll be coming to it during the final decision on how to present. So, swelling in the neck. So this is a differential diagnosis, and these are the history that you need to ask for. So any thyroid swelling or a goiter. So thyroid enlargement is known as goiter. So we have the toxic and the non-toxic type of multinodular goiter. We have toxic and non-toxic solitary nodule thyroid. There is thyroid neoplasm, thyroiditis, Graves' thyrotoxicosis. Now, another condition is thyroglossal cyst, again a midline condition. Sebaceous cyst or a lipoma or a dermoid cyst. These are other swellings that can be present anywhere. A branchial cyst slightly towards the lateral aspect of the neck. Enlarged cervical nodes are also swellings in the neck. They can be a tuberculous lymph node, or it could be a secondary from carcinoma thyroid. That is also sometimes known as the lateral aberrant thyroid, where it is seen as a lateral swelling and is also moving in deglutition and is considered to be a swelling arising from thyroid gland, but in reality it is not a swelling arising from thyroid gland. Instead, it is a secondary in a lymph node. So it is a metastatic papillary carcinoma thyroid, which is, as a misnomer, it is known as lateral aberrant thyroid. So these are the other conditions. There are many more conditions that can be seen in the neck, but these are the most relatively common type of conditions that we can see. Now, difficulty in swallowing or breathing. So that, as far as thyroid disease is concerned, it can be due to a large goiter, and it also could be due to thyroid malignancy, where the malignancy infiltrates or presses on to the recurrent nerve or the esophagus. Now, there are other causes, and a few of them common ones are the sore throat, pharyngitis, tonsillitis. These are all associated with difficulty in swallowing. Then there are other conditions for difficulty in breathing, You can have a cardiac condition or a respiratory illness like chronic obstructive pulmonary disease or COPD. So all of this can be responsible for difficulty in breathing. Similarly, for hoarseness, compression by a large goiter, infiltration of the nerve by the thyroid malignancy. Other causes, you can have the polycystic ovarian disease or PCOD, laryngitis, and still many more. So I just mentioned one or two here as other causes. So what we are concerned with is a thyroid disease presenting with this symptom. A recent weight loss in spite of the increased appetite. So the usual cause is thyrotoxicosis. However, we have other conditions that can cause significant weight loss. We have tuberculosis, cancer, cachexia, that is where the cancer begins to have systemic effects and there is rapid weight loss. Then diabetes mellitus also can cause significant weight loss. Now, for recent weight gain in spite of decreased appetite, so the condition is hypothyroidism. So I'm just mentioning it. When a presenting complaint comes, we must know what are the options and what are the most common options before going into history taking. So, history of present illness. So here the chief complaint was a swelling in the front of the neck. So here I'm going to arbitrarily decide a duration. So I've selected as 10 years. Now for each complaint, we're going to have to see the status before the complaint, then how the complaint began, where it is and what's the duration, and how it progresses over the duration and its present status, associated complaints, and accordingly. So since thyroid is a special case, we're going to have some additional things regarding a history taking on a swelling that is in the neck. So the status before complaint, the preferred way of saying it is patient was apparently normal 10 years ago. So this helps us to understand that patient was normal and then the patient noted the complaint. She incidentally noticed a swelling in the front of the neck 10 years ago. So that is about the complaint, how it was seen and the duration and the site. So patient is apparently normal 10 years ago. She instantly noticed a swelling in the front of the neck 10 years ago. Now regarding the onset, so we have usually the insidious onset and the acute onset. So if you use the comment onset was insidious, so we have some thyroid diseases which have insidious onset. Multinodular goiter, salty-nodule thyroid, thyroiditis, thyroid neoplasm. So now what about the onset if it was acute? Then we have the Graves' thyrotoxicosis. Then we have viral thyroid. There is a type of thyroiditis that occurs during acute viral infections. As part of the viral syndrome, you may have pain and swelling in the neck, which may be part of the thyroiditis that develops along with the viral infection. So, in general, if it's a multinodular goiter or any other, because or salty-nodule thyroid, you can go ahead with the onset was insidious. Now we will go further about the complaint. So about the progression of complaint with the initial status and present status. So this is one of the preferred statements. The swelling was initially small in size and gradually increased in size over the last 10 years to attain its present size. So that explains how it grew and what was the size before and how it has reached its present size. Now here earlier it used to be compared to fruits and vegetables. What was the initial size, lemon, lime, and then it became a lemon later, like that. But today it is not referred. You can just say it's small and then it is now its present size. Anyway, we are going to examine to know the present status. So, and a few other options of how you can write this is, the swelling was initially small in size and remained the same for the first 7 years, and then increase in size over the last 3 years to attain its present size. So this is another way the course could go. And another way is, the swelling was initially small in size and gradually increased in size over the last 10 years until 3 months ago, when there was a sudden onset, rapid increase in size to attain its present size. So here we can say the same thing but with a recent change in the swelling. We'll come to that little more now. So the next part would be history of recent rapid increase in size. So if there isn't any, you can just say there is no history of any recent rapid increase in size. Now, if you already know it and you have mentioned it in the previous way, that is good enough. But if you have said it in a different way, as in you selected the first option or the second option, then you can go on saying that there is a history of rapid increase in size over the last 3 months. But I would prefer it that it be said in the third way. The swelling was initially small in size and gradually increased in size over the last 10 years until 3 months ago when there was a sudden onset, rapid increase in size to attain its present size. Now, what is the cause for a recent rapid increase? So, one cause is hemorrhage into a nodule in the multinodular goiter. So, there is pain as well as size swelling increase. Second option is malignant transformation of a part or a nodule in the swelling. Now, the next history is history of associated pain or discoloration of overlying skin or in discharge of pus. So, the swelling is associated with pain and discoloration or redness and or pus discharge from overlying skin. So, if you think there is redness or discoloration and there is pain and there is also discharge of pus, and if the patient is saying all of that, then you can say this. Remember, this is history taking and not examination. So, we need to hear it from the patient's mouth. So, what are the options we have when such a thing happens? So, it could be an inflammatory swelling. It could be an infected thyroglossal cyst, an infected sebaceous cyst. It could be an abscess, a furuncle or a boil. It could be a tuberculous sinus. It could be thyroiditis or it could be a hemorrhage into a nodule. Now, in hemorrhage into the nodule, there won't be any discoloration of the skin or any pus discharge. Usually, there will be only pain and there will be a slight increase in size. So, this is one way. Next, the second option is the swelling is not associated with any pain or discoloration or pus discharge of the overlying skin. So remember, this and the previous statement are related. So we need to go in sequence when you say such sentences. Again, we will be dealing that towards the end when we finalize on how to write the history taking. Now the next history is history of pressure symptoms. So usually a thyroid swelling can present with pressure symptoms. I already mentioned to you that instead of mentioning as a chief complaint, it's better to say it now as part of the pressure symptoms. There is a history of difficulty in breathing or difficulty in swallowing or hoarseness since the last 2 months. So whichever symptom is there, you can mention that. And whichever is not there, you can say that is not there. So the usual cause I mentioned earlier is large goiter or a thyroid malignancy, or it's a malignant transformation in a previously benign swelling. So the second option is that you don't have such symptoms, so there is no history of any difficulty in breathing or any difficulty in swallowing or any hoarseness. So this is the two way of saying it. Now the next is in the case of a neck swelling, and since our top diagnosis is the thyroid swelling, thyroid gland secretes hormone, so you can have an increase in hormone or a decrease in hormone. So we need to ask the history of thyrotoxicosis as well, irrespective of whether it's a thyroid swelling or not. So there is a history of recent significant weight loss in spite of increased appetite. There's a history of anxiety, restlessness, tremors, heat intolerance, preference to cold, PAMA sweating, menstrual irregularities, insomnia or difficulty sleeping, bulging out of or prominent eyes, or double vision or palpitation. So these symptoms are all included for all forms of thyrotoxicosis. So you can have a toxic multinodular goiter, a toxic saltinodular thyroid, Graves' thyrotoxicosis. You can have the toxic phase of thyroiditis. You can have a thyroid malignancy presenting as thyrotoxicosis. That's usually seen in 2% cases. So here, this is one way of saying, now whichever symptom is there, you need to mention only them. And the others are not there, can be mentioned. Now if none of them are there, you can go ahead with this. There is no history of any recent change in weight or appetite. There is no history of any anxiety, restlessness, tremors, heat intolerance, preference to cold, palmar sweating, menstrual irregularities, insomnia, bulging out or prominent eyes, or double vision or palpitation. So, relatively, what do we do see is the weight loss and the increased appetite, heat intolerance, tremors, palmar sweating. These are things that we usually, and sometimes in a later stage, untreated stage, you'll see the bulging out of the eyes as well. Now, double vision is relatively a very late symptom and usually seen in the case of ophthalmoplegia. Similarly, palpitation is seen when the patient already has a pre-existing multinodular goiter and became toxic. So it's a form of secondary thyrotoxicosis. Okay, anyway, so we'll move on. Now, what if there was the opposite? There was history of hypothyroidism. Again, you can ask it as there's a history of weight gain in spite of decreased appetite. There is a history of cold intolerance, preference to heat, dry skin, facial puffiness, tiredness, lethargy, daytime sleepiness, poor memory, menstrual irregularities, mainly menorrhagia, that is increased menstrual flow, or infertility. There's a history of infertility or constipation. Now, the common conditions include multinodular goiter and thyroiditis. Now, if you have no history of hypothyroidism, you can go ahead with this. There's no history of any recent change in weight or appetite. So that's a common statement for both. There's no history of any cold intolerance, preference to heat, dry skin, tiredness, lethargy, daytime sleepiness, poor memory, menstrual irregularities, or infertility or constipation. Now, here I would like to say something that menstrual irregularities will be again dealt with under personal history, and similarly, if it is a male patient, do not ask about menstrual histories in such a case for the obvious reason. Now, the next is negative cardiac history. Since you may have a few symptoms like difficulty in breathing and palpitation, so we need to have a generalized negative history for the cardiac history. Similarly, we will later on deal with the pulmonary history as well. So there is a history of chest pain or breathlessness on exertion or cough. Or you can go ahead with this, no history of any chest pain or breathlessness on exertion. So that would rule out other cardiac conditions. So now what if the thyroid swelling? So we have dealt with the thyroid swelling, that is a benign swelling, that is a huge swelling, that is a malignant, that's a inflammatory swelling, and the other inflammatory conditions in that area. Now what if it's a hormone secreting one, or if it's a hormone deficient one? And now what if it's a thyroid swelling that has spread to other sites? So this is the way of approaching that. There's a history of another swelling in the neck. So in such a case, again, you would have to mention the onset of that swelling and how it has increased in size since the time you noted it, and if it is associated with any pain. We don't have to go into too much details because we have not said it as a chief complaint. Instead, we have said it as a negative history, that is history of metastasis from a thyroid malignancy. So what is the reason for another swelling in the neck is a lymph node, an enlarged lymph node due to metastasis from a papillary carcinoma or a medullary carcinoma or an anaplastic carcinoma thyroid. Now here I would like to also mention that sometimes in other scenarios, not in this case, either thyroid malignancy may present as a neck swelling alone, that is as an enlarged lymph node and not without any palpable thyroid tumor or thyroid malignancy. So that is a different case. Here we are mentioning a patient who has a thyroid swelling with a neck swelling, additional neck swelling. Now there's a history of scalp swelling. So there again you have to mention the onset. So for all of these cases you can go for an insidious onset. Then the progression since the time it has been there, and if that is associated with any pain. Now here, why do we ask that? Is because of metastasis to the bone from follicular carcinoma thyroid. So we have two types of metastasis: papillary carcinoma going for a lymph node in the neck, and follicular carcinoma going for a scalp swelling. Now, for metastasis to other systems, for lung metastasis, you can ask there's a history of cough, breathlessness, or hemoptysis. For vertebral or liver metastasis, you can go for there's a history of low backache or any yellowish. There's a history of yellowish discoloration of skin and sclera. Now, if none of these are there, it's a completely negative history for spread. You can go with like this. There's no history of any other neck swelling or any scalp swelling. There is no history of any cough, hemoptysis, or breathlessness. There's no history of low backache or any yellowish discoloration of skin or sclera. That would effectively rule out everything. Now we will go into the different forms of other history. So we have dealt with the chief complaint, the history of present illness. Now we're going to go for past history, personal history, family history, socioeconomic history, and treatment history. And then we'll finalize on the wordings of a patient who presents with a thyroid swelling with no other history. So past history, what do we ask here? Whether there was a history of a similar illness in the past. Yes, a patient can have a thyroid swelling 20 years ago, underwent a surgery, can go undergo a surgery 15 years ago, and now again can present with another swelling of 10 years duration. So a multinodular goiter or a saltinodal thyroid, or in some cases even a medullary carcinoma or anaplastic carcinoma in whom they did a surgery can actually have a recurrence. Medullary carcinoma is having a recurrence rate of near 50%, anaplastic carcinoma much more, maybe 80% more. Since it's a relatively rare condition, it is having a very high chance for recurrence. So there is a history of neck surgery done 15 years ago. So if there is a history of similar illness and some surgery was done, then this would be the way of saying it. So which all surgeries can occur? A subtotal or a near total thyroidectomy or a hemithyroidectomy. All three of them are known where you have left some gland behind, and so recurrence can happen. In the case of lymph node biopsy for a lymphoma or tuberculosis or tuberculous lymphadenitis, again the pathology may still be recurrent or can reappear. So these are the conditions where you can have a recurrent neck swelling. There are many more, but this is the more relatively common conditions. There is a history of irradiation of the neck at the age of 10 to 11 years. So you can say like that. It's a sample here. Whichever the age at which they did it, you can say it. So that is a usual treatment. That is a head and neck radiation for a head and neck lymphoma, usually seen during childhood. Again, another aspect is that a person who has underwent such a irradiation to the neck is also a risk factor, a predisposing factor to the development of papillary carcinoma thyroid, maybe 15 to 25 years later. Now, next is the regular history which you ask for as part of preoperative assessment. There's a history of hypertension or diabetes mellitus, asthma, COPD, that is chronic obstructive pulmonary disease, or ischemic heart disease. So that is a routine we ask just to know what all medicines are likely to be taken by the patient in view of the history. So the negative history again, that is, if you don't have any of this, then this is how you would write it. There is no history of any similar illness in the past. There is no history of any previous neck surgery, which includes both surgeries, the lymph node biopsy as well as the thyroidectomy, so or any irradiation to neck. There is no history of any hypertension, diabetes mellitus, asthma, COPD, or any ischemic heart disease. Now the next aspect is personal history. So sleep can be decreased in thyrotoxicosis, which amounts to insomnia, increase in hypothyroidism where the patient is sleepy throughout the day, evening, as well as in the night. Appetite will be increased in thyrotoxicosis, decreased in hypothyroidism. The diet can be non-vegetarian or vegetarian. Now, there is some implication of a diet which is heavy with vegetables from the Brassica family, like cabbage, cauliflower, etc., can cause hypothyroidism. But however, it's not significant in daily life, as most individuals eat most types of vegetables as well as non-vegetarian food. Now, regarding addictions, so you can document regarding smoking and alcohol. Now, menstrual history, amenorrhea, that is absence of the periods for a period. Oligomenorrhea, that is a slightly increased gap between the periods, both are seen in thyrotoxicosis. Now, menorrhagia, as increased flow during the menses period, is seen in hypothyroidism. Now, regarding marital history, if there's a history of infertility post marriage or a history of recurrent abortions, then we must consider hypothyroidism as well as autoimmune causes of hypothyroidism. Now, hypothyroidism is a separate topic. We have dealt it under the theory topics. You can refer that for the theory aspect. Now, remember, this is a class on case presentation. So, if you were to have a normal personal history, this is how you would write it. Sleep is normal, appetite is normal, diet is non-vegetarian or the vegetarian one, whichever you can select. Some people used to refer them as mixed whenever you wanted to say non-vegetarian. But you can mention like this. The bladder habits are normal, the bowel habits are normal. Now here I must mention that bowel habits, you can develop constipation during hypothyroidism and diarrhea because of thyrotoxicosis. Similarly, if there are no addictions, you can mention no addictions. The menstrual history, the menarche was at the age of 10 years or 11 years accordingly. The periods are regular with 5 to 6 days flow and is every 28 to 30 days. It's a normal cycle. Menopause, if it is an elderly age, you can go for menopause at the age of 52 years or 50 years, whichever is her age. Similarly, regarding marital history, patient is married with 2 children, you can mention that. So this is the way of saying it. Now, in a few other formats are there where not usually seen in thyroid in surgery, where the menstrual and marital history are set separately, especially in a patient presenting to the gynec department. So here we can mention it under the personal history. Now remember again, menstrual history should be avoided if it is a male patient. Now the next is family history. So there's a history of similar illness in the family. Yes, multinodular goiter can be familial. Medullary carcinoma thyroid can be familial, associated with men as well as familial without any association with the men syndrome. So medullary carcinoma thyroid runs in families. Similarly, there is a papillary carcinoma thyroid can run in families as well as can present as part of certain syndromes. So that is about the history of similar illness in the family. Similarly, if you have a history of thyroid cancer in the family, there is a chance that the patient also can develop thyroid cancer. Now there's a history of hypertension, diabetes, mellitus, asthma, tuberculosis. This is general history taken to know whether we should assess for such systemic diseases in the patient, even though the patient does not have any of them. So if you have a negative family history, you can go for there's no history of any similarness in the family, there's no history of thyroid disease or thyroid malignancy, there's no history of any comorbidities in the family, or you can mention there's no history of any hypertension, diabetes, asthma, ischemic heart disease in the family. So it's your way of saying it. Now the last 2 elements is socioeconomic history and treatment history. So patient belongs to a middle class family, or if it is a lower class, you can do that, or upper class, you can say that. There's not much relevance to thyroid disease. Now regarding the treatment history, she gives a history of hypothyroidism for the last 12 months or the last 2 years, and is on the tab thyroxine. If you know the dose, you can say it. She gives a history of thyrotoxicosis for the last so and so months, or if it's 1 year, you say that, and it's on tab carbimazole. So whichever the antithyroid drug, you can mention that. So whichever is happening, if it is hypo, you say that. If it's thyrotoxicosis, you say that. Then she is on treatment for hypertension, diabetes mellitus, or coronary artery disease. So if she's on any of these, you can mention the tablets, especially CAD or coronary artery disease, where patient may be on ecospirin or clopidogrel, so which is important to stop these medicines prior to the surgery. So that is about the discussion on the presenting history, on the history of a patient presenting with the thyroid gland. So now we are going to discuss the format, not discuss, we are going to state it in a patient who presents with a swelling. So the name is Shobana, age is 50 years, she is female, she is a housewife, and she lives in Calicut, Kerala. So you can say Shobana is a 50-year-old female, who is a housewife and staying or residing at Calicut in Kerala. Her chief complaint is a swelling in the front of neck of 10 years duration. History of present illness. Patient was apparently normal 10 years ago. She instantly noted a swelling in the front of the neck 10 years ago. The swelling was initially small in size and gradually increased in size over the last 10 years to attain its present size. There is no history of any recent rapid increase in size. The swelling is not associated with any pain or discoloration or pus discharge from the overlying skin. There is no history of any difficulty in breathing or any difficulty in swallowing or any hoarseness. There is no history of any recent change in weight or appetite. There is no history of any anxiety, restlessness, tremors, heat intolerance, preference to cold, palmar sweating, menstrual irregularities, insomnia, bulging out or prominent eyes, or double vision or palpitation. There is no history of any cold intolerance, preference to heat, dry skin, tiredness, lethargy, daytime sleepiness, poor memory, menstrual irregularities, or infertility or constipation. There is no history of any chest pain, chest pain or breathlessness on exertion. There is no history of any other neck swelling or any scalp swelling. There is no history of any cough, hematitis, or breathlessness. There is no history of any low back ache or any yellowish discoloration of skin or sclera. Past history. There is no history of any similar illness in the past. There is no history of any previous neck surgery or any irradiation to neck. There is no history of any hypertension, diabetes mellitus, asthma, COPD, or any ischemic heart disease. Regarding the personal history, the sleep is normal, appetite is normal, the diet is non-vegetarian, bladder habits are normal, bowel habits are normal, there are no addictions. Regarding a menstrual history, the menarche was at the age of 10 years. The periods are regular, 5 to 6 days, every 28 to 30 cycles, 30 days. Menopause attained at the age of 46 years. Marital history, she was married with 2 children. Now, regarding the family history, there is no history of any similar illness in the family. There is no history of thyroid disease or thyroid malignancy. There is no history of any comorbidities in the family. Socioeconomic history, she belongs to a middle class family. Regarding treatments, there is no history of any treatment for hypothyroidism, hyperthyroidism, hypertension, diabetes mellitus, or coronary artery disease. So, that is the way we could present or document the history of a patient who presents with thyroid swelling. We can ignore some of the other presenting complaints to make it easier to document and present. In the next section, we'll deal with the examination. So, thank you.